Hello friends, Dr. Kofi here again, and welcome to my YouTube channel, TutorMed, where everything medicine is simplified. In this episode, we will have a clinical case discussion in pediatrics, and this will be our second pediatrics tutorial. Please remember that although these are clinical case discussions where we look for answers to the questions asked, we use the opportunity to study more about the disease condition like we will do today. And so if you are new here and are preparing for any licensure exam, consider subscribing and turn on your notification bell so that you can be notified anytime we upload new videos. Kindly remember to like and share this video and leave your thoughts in the comment section below. Your notepads ready? Let's get started. And so let's see our clinical case. The clinical case reads: a 4-year-old girl is brought to your consulting room by the mother with complaints of fever, vomiting, and refusal of feeds. She says her child has become slow and is not playing with her doll like she previously used to. You decided to do malaria tests and the results came back negative. Now there are 4 questions for this clinical case. The first is, what is the most likely diagnosis? And so as usual, let's spend some seconds thinking through this case. Very good. And so for this case, the relevant information include: 1. She is a 4-year-old girl. 2. Came with complaints of fever, vomiting, and refusal of feeds. Then another important term is that she has become slow and is not playful like she used to. Very importantly, the malaria test done is negative. Now, what is the most likely diagnosis? The answer to this question is enteric or typhoid fever. Now, this is a typical case of an approach to fever in children, and it could be any febrile illness, like we will explain in our next slide. Any febrile illness can explain this child's presentation. But sometimes, for short answer clinical questions like these, the information might not be enough to get the diagnosis the examiner expects of you. But sometimes, carefully examining the questions asked might give you an idea of what the examiner is expecting. And so this is a trick I am suggesting to you that when used, it may help you to narrow the differential diagnosis. And we will see how the questions that followed helped narrow the diagnosis. Very good. And so for this child, many infectious diseases may explain her clinical presentation per the information given. Conditions including: 1. Malaria. But what ruled malaria out? The fact that the malaria test done was negative. Again, meningitis can explain her fever, vomiting, and poor feeding. The question, in my opinion, was not so gracious with the information, like maybe any associated neck stiffness or recent travel to a meningitis endemic area. And so in the real life situation, meningitis should be considered. Another differential or condition which may explain this child's presentation is tonsillopharyngitis, inflammation of the tonsils and then the pharynx. It may explain the fever, the child refusing to eat, and the child becoming dull, the child vomiting. Another cause of fever in this child can be acute otitis media, bacterial otitis media, which is the infection of the middle ear. It can explain the fever, the vomiting, and the child refusing to feed. And so in real life situation, questions like ear tagging, ear discharge, a prior or an antecedent upper respiratory tract infection should be asked this child. Then another condition which may explain this child's presentation is pneumonia. Although vomiting is not a typical symptom of pneumonia, sometimes these children may vomit. Then we come to the next differential, which is enteric fever, our chosen diagnosis. Enteric fever, like we will see later, is a systemic illness caused by the dissemination of Salmonellaparatyphi or paratyphi. What made us choose enteric fever was that there was another question which read, mention 2 bacteria responsible for this condition. Then it drew our attention to the fact that it could be enteric fever. Then other conditions can include osteomyelitis, which is infection of the bone and its marrow. And then, yes, urinary tract infection can explain the fever, can explain the vomiting and the refusal of feeds, particularly when this patient is a girl. You know, ladies are prone to having UTIs, and so UTIs may explain this patient's presentation. So in real life situation, when given the chance to evaluate these patients, questions like unusually foul smelling urine, dysuria, frequency, urgency should be asked the mother. Good. And so please do not forget to like and share this video and subscribe to our channel if you have not done that yet. Leave your thoughts in the comment section below. Kindly remember that although we are discussing clinical cases looking for answers to the questions which have been asked, we want to use this opportunity to learn a little about the case under discussion. And so let's learn a little about enteric fever. Now, enteric fever is a systemic illness. It means it doesn't affect just one part of the body, which is characterized by fever and abdominal pain. And this systemic illness is caused by dissemination or widespread of Salmonellatotyphi and Salmonellaparatyphi. Now, the term enteric fever is a misnomer, meaning the name given to the condition does not accurately define the disease. In that, the hallmark features of the condition, which are fever and abdominal pain, are actually variable. They vary in frequency of occurrence. What I mean is, for example, fever has been documented to occur in more than 75% of cases, and that is a reasonable percentage. Abdominal pain, however, occurs in only 30 to 40% of patients with enteric fever. It means that if you pick 10 patients with enteric fever, only 3 to 4 patients would have abdominal pain. And so a high index of suspicion is needed to diagnose the condition when evaluated. Now, how is the disease transmitted? How did our little girl get infected? The transmission is a fecal-oral transmission, meaning we get it when the feces of an infected individual or a chronic carrier contaminates anything we take by mouth, which can be food or water. And so, for an example, in this case, in this little girl's case, say if the mother is a carrier and then she uses the water closet or the lube, she discharges salmonella containing feces into the water closet and may end up contaminating her hands when cleaning herself up. Now, she doesn't wash her hand properly, and then she prepares food for a little girl. The salmonella contaminates the food. Then the little girl unfortunately eats the food. Now, if the load of the salmonella on the food is the infective dose, meaning the amount of salmonella organisms required to infect an individual, the little girl might get infected. And so that is the fecal-oral transmission. Now, unfortunately, this little girl ate the food which has been contaminated with or by the Salmonella organisms, and the infective or the Salmonella load was actually the infective dose. Now, when the organisms get into the GI system and they manage to survive the GI environment, particularly the acidity of the stomach, they get to the small intestines and then they invade the terminal ileum. Now, which part of the terminal ileum do they like to invade? They like the epithelial cell lining, and then a group of lymphoid structures below the epithelial cell lining called the Peyer's patches. Now let's see these two victims of the Salmonella organism using this diagram. And so this is the cross section of the terminal ileum. This is the internal lining or the epithelial cell lining, and then below or underneath the epithelial cell lining or the mucosa, we have these lymphoid structures called the Peyer's patches. And so the Salmonellatyphi likes to victimize these two guys, and after going through or after invading them, they go through the wall of the terminal ileum into other structures, which we will see in a minute. And so after going through the wall of the terminal ileum, the organisms invade the lymph nodes of the gastrointestinal system. These lymph nodes are called mesenteric lymph nodes. From there, they move into the lymph vessels or the lymphatics, and eventually these lymphatics would dump them into the bloodstream. Now, the first time they find themselves in the blood is called primary bacteremia, and at this point the patients will show few or no symptoms at all. Then while in the blood, the heart pumps them everywhere, but the organisms prefer the cells of the reticuloendothelial system. Remember, we mentioned a similar thing like this when we were discussing measles, that the cells of the reticuloendothelial system are mostly macrophages. And so another term for reticuloendothelial system is monocyte macrophage system. And so the organs which make up the reticuloendothelial system mainly are the liver, the spleen, the bone marrow, and then the lymph nodes. And so the Salmonella targets the macrophages in these organs. So they invade the macrophages of these organs and multiply in them, after which they are spilled into the blood again. Now, the second time they find themselves in the blood after they've multiplied in the macrophages is called secondary bacteremia, and it is at this point that the symptoms and signs develop classically, and so mark the end of the incubation period. The typical incubation period for enteric fever is 7 to 14 days, although some books have documented 10 to 14 days. Very good. And so quickly, let's see some of the clinical features or some of the signs and symptoms of enteric fever before we move to the next question in the clinical question, which was asked. And so some of the clinical features include fever, which can be prolonged for as long as 3 weeks. Then we can have generalized myalgia or generalized muscle ache. Then we can have abdominal pain. Patients may be anorexic, like our patient had. They may be vomiting. Again, there may be hepatosplenomegaly. And in about 25% of patients, they develop this skin rash known as rose spots, which may begin on the chest or the abdomen. Now, since we are talking about enteric fever in children, our clinical case, let me bring this information I got from Nelson's textbook of pediatrics. Remember, this book is one of the highly recommended pediatric textbooks in medical schools. The information is actually a data which was collected in Pakistan to evaluate the most common clinical features of enteric fever in children. And then in descending order, meaning beginning with the most common, it was found that the most common clinical features include features of enteric fever in children include 1. High-grade fever. High-grade fever was found to be one of the most common presentations, like our patient had. And then the second most common was anorexia, like our patient had. She refused feeds. And the third was vomiting, like our patient had. Then the patient may have hepatomegaly, followed by diarrhea, abdominal pain, and then the list goes on. The reason why I brought this information is that see where abdominal pain is, see where it featured, emphasizing the earlier point we made that you don't need the presence of abdominal pain before you think about enteric fever for a patient who presents with fever, particularly when the fever is prolonged and it is still there despite anti-malarial treatment. You need to think about enteric fever. And so abdominal pain, although it's in the definition, is not really a common finding among patients. And so remember, high-grade fever, anorexia, vomiting, and even diarrhea, which may alternate with constipation in children before the abdominal pain sets in, or you think of abdominal pain. Very good. And so kindly break here and then have some time to like and share this video. And again, kindly be reminded to subscribe to our channel if you have not done that yet. Now, the second question in this clinical vignette says, mention 2 medications you will give this child. So we go back to the question and we realize that the patient came with fever. So what do? We would give IV antipyretics, and typically we give paracetamol. And because we are thinking of enteric fever, we give IV antibiotics. And then classically we give either ciprofloxacin or ceftriaxone. Then the question has asked us for 2 medications, and so we end there. But other medications we can give is IV fluids, although typically it is not a drug, but it is considered medication. Then we move to the third question. The third question reads, mention 2 bacteria that can cause this disease. And so yes, coupled with the non-specific clinical features given in the clinical stem, this follow-up question was the one which drew my attention to the diagnosis enteric fever. And so the 2 bacteria are Salmonellatotyphi and Salmonellaparatyphi. These are known as the typhoidal Salmonella species. Now, I will give you an example of how the question can lead you to the diagnosis. Back in medical school, on one of the OSCE stations, we were given a CSF report to analyze and answer the questions that followed. Now, upon analysis, the CSF report looked like it could be fungal and it could be tuberculous meningitis. And so the first question was, what is the diagnosis from this CSF report? Then we were like, should we write fungal meningitis or tuberculous meningitis? But guess what? One of the follow-up questions asked, what 4 medications will you prescribe for this patient? On seeing this follow-up question, we knew that it would be totally unwise of us to write fungal meningitis, because it is in TB patients that we prescribe 4 medications typically. You remember them, right? We remember them with the acronym RIPE. R for rifampicin, I for isoniazid, P for pyrazinamide, and E for ethambutol. So the point here is that when confused about the answer, particularly the diagnosis, let the follow-up questions guide you, because sometimes they may lead you to get what the examiner is expecting of you. Good. And so the last question says, mention 2 complications of this disease if not treated immediately. Now please remember, it is a systemic illness, and so it can have an effect on almost every organ. And so beginning with the head, it can cause meningitis, it can cause cerebral abscess, it can result in encephalopathy. All these conditions can ultimately cause seizures in this patient. Then, in the heart, it can cause myocarditis, it can cause pericarditis. Then in the chest, it can cause, or in the lungs, if you will, it can cause pneumonia. It can cause infection in the bone and its marrow, so osteomyelitis. Sometimes, although not so typical in children, it can cause terminal ileal perforation. It may result in hematologic complications like disseminated intravascular coagulation. And so this is the end of today's pediatric tutorial. Kindly be reminded to like and share this video. If you have not done that, go back and give us a like, share the video to whoever might need it, and then subscribe to our channel if you have not done that yet. Thank you for watching, and see you in our next video. Until then, bye.